so looks like most people are picking C. By the way, this is Advanced Patient Care Theory 2, Unit 2, Part 3, second half here. So most people, your patient is in labor. She has one child. What's her gravida and para? Most people are answering gravida 2, para 1. And the answer is indeed gravida 2, para 1. Let's try the next one here. Your patient is in labor and she had a previous spontaneous abortion and has 2 children. What's her gravida and para? And again, you can just text that in the box below, right hand corner. And who is in here as a guest? I see a guest here. Who is that? All right, guest, if you're one of my students, I'm going to kick you out and you can come back in. You can come back in with your name. Answer D, gravida 4, para 2. And the answer is gravida 4, para 2. So if we look at the patient is in labor, that's a gravida. She has 2 previous spontaneous abortions. That was a gravida and a gravida. And has 2 children. That's a para and a para. And
there's only one abortion, Rob.
Oh yeah, sorry, you're right. All right. Well, anyway, the answer is gravida 4, para 2. And assessment of the pregnant patient. So we want to know if this is a first pregnancy, and if that's the case, we probably are not in a big hurry to delivery. Yeah, someone had their hand raised. Oh, let me unmute your mic. And multiple births obviously are going to be a quicker delivery, so we need to anticipate the delivery. So here's the next question. Your pregnant patient has 3 children at home. What is her gravida and para? Again, you can text it. Okay, most people are answering B. Oopsie, what happened there? Most people are answering B, and that would be correct. Gravida 4, para 3. Looks like it skipped 18 with the answer, so my apologies. Okay, so this one, your pregnant patient has 2 spontaneous abortions and has 3 children at home. What is her gravida and her para? Oh, there we go. Now it shows me 18. It's 19. What is her gravida and para? Again, you can text it. Most people are saying D. And the answer should be D. Let's see what happened here to 20. There we go. Okay. Yeah, if someone can stop playing with the slides, I'd be grateful. All right. So, general management. Vaginal exams, yes or no?
No.
No. Okay, good.
No.
Okay. Terry, you had your hand raised?
Yeah, I was just wondering, GPA, so you're just doing the GP. Is that a hospital scoring with when you add the abortion to it?
Yeah, that's a typical hospital scoring. But what were you thinking?
Oh, I'm just wondering why you're not doing the A part.
Yeah, do you want to just explain the A part to us?
The abortion, the GPA, the number of pregnancies, the partums, and the abortions.
That's right. Yeah, I mean, some people quantify that sort of separately, but
Oh
everything you
yeah.
say gravida 4, para 1 usually is part of the history. The A part is sort of thrown in there.
What's L?
Uh,
MJ.
The hospitals go gravida, term, para, abortion, living children.
so he faded away on us there. Can you say that again?
So when the hospitals score it, they go by GTPAL, gravida, term, para, abortions, and living children, I believe.
Yeah, yeah. Yeah, it depends on what hospital you're in. I've just kept it simple to gravida and para, which is what most hospitals still use. But yeah, okay. Are any of you doing your birthing unit rotation right now? Starting with that rotation? I assume that's a no.
We finished 1 week where
What?
Josh just did his NICU last week.
Really? Your first week?
Yeah.
And did he see anything? Do anything?
I'll let him explain,
Oh, there.
wherever he is.
Josh, you need to unmute your mic.
Well,
Okay.
to give you spoilers, he delivered a baby.
Oh, excellent.
Yeah.
Actually delivered it, or was there to witness it, or?
Apparently he was the catcher and all.
Wow, that's amazing. Which hospital was that at?
Aurelia.
Wow, that's unbelievable. You might actually be our
Yeah.
first.
The doc was late, right?
Yeah. The doc was late and the nurses let him do that?
Yeah.
Yeah.
Well, apparently the doctor wasn't present. It was just him and a nurse.
Yeah. Wow. Wow. I'm shocked.
Yeah.
Okay, so important to always remember that when we go to an OBS, a labor and delivery call, we're dealing with 2 potential patients. So I guess it depends on where you work. Our process is to call for a backup ambulance, one for baby, one for mom, just in case. We usually transport them separately for safety, but it's one of those things where it depends on your policy. In terms of monitoring devices, just the usual pulse oximetry for the baby, monitors for the baby. The trouble with taking both mom and the baby in one ambulance is you don't have any ability to. You're going to be monitoring baby. You don't have any ability to monitor mom other than just speaking with her. In terms of other things to do for management, the big decision we have to make obviously is when do we transport, when do we stay, and if there's I'm having trouble advancing slides. I apologize. There we go. and then positioning the patient in the ambulance. How do we do that? What's the preferential treatment for mom if she's not delivering? We're just transporting her.
Lateral.
Left lateral, good. And how would you get her left lateral?
Blankets under her butt.
Yeah, just a roll blanket or a pillow. Yeah, so we're trying to avoid vena cava hypotension, so the weight of the uterus compressing the vena cava and decreasing venous return, and to avoid hypotension. And we want to monitor both mom and baby, and auscultation of heart sounds, fetal heart sounds are probably futile. So we always want to be prepared to resuscitate 2 patients, and I think it's important to be in that sort of mental state. And if you're in that mental state and you're prepared, sort of prepared equipment-wise and everything else, it's probably not an issue. Now, what about starting an IV on mom? You've got an uncomplicated, you've got a mom who's, let's say, gravida 3, para 2, no complications during the pregnancy, no complications with the previous pregnancies. You're anticipating normal delivery, and the baby is crowning, and you've got 2 crews at the scene. Start an IV on mom or don't start an IV on mom?
Treatment, immediate treatment priority.
Sorry, it is or is
We
it?
normally don't do that.
Yeah.
Well, I don't think it is. If everything's uncomplicated, there's no risk of postpartum hemorrhage, then it wouldn't be a priority treatment, I don't think.
Yeah, I agree. I don't think it's a priority, although I wouldn't criticize anyone for doing it. So I'd say yes or no. Here's the way I look at it too. The directive says potential or actual need for fluids or drugs for the patient. So if there's no real potential for fluid resuscitation, no real potential for drug administration, then I would say no one would criticize you for not starting an IV, and no one would criticize you for starting an IV. I probably wouldn't start an IV. That's just my opinion.
Rob?
Yeah.
Rob, when we're going to get Pitocin, is that going to be subcutaneous, IM, or IV?
Yeah, it's a good question.
Do you know?
I don't know. MJ, can you shed some light on that? Do you know about oxytocin?
I know just a little bit from reading up on the uses in an emergent setting. And
No, I mean from a
let's see what I wrote.
directive perspective.
I don't know much from the directive perspective. I do know it can be delivered IV or IM, but in regards to the directive, I believe it's going to be specific for postpartum hemorrhage.
Right.
And beyond that, I don't know anything else.
Okay, fair enough.
But IV, IM.
Fair enough. Okay, thanks, guys. We're going to take let's take a 15-minute break till 9 o'clock, and I'll get the next set of slides set up.